services to our patients. But we also want to deliver good prevention services to our patients also. So one of the things that we have been working on for the last several years is integrating our behavioral health services with our medical services. We have spent a considerable amount of time working and focusing on expanding and enhancing our behavioral health screening services in our medical departments. Why? Because it gives us the best opportunity to serve the greatest number of people in our communities. Our objective for our work is that we want to screen every single medical patient for behavioral health problems. That's our objective. And then we also want to provide assistance to every single patient who has a positive screen. That's a big job. But by doing it that way, we have the opportunity to prevent mild problems from becoming moderate problems from becoming severe, and we can help prevent people from losing their lives, right? We're doing a life-saving work. It's important. It's significant. So what I'm going to do today is I'm going to share some ideas with you that I think you could take home. This is actually things that you can do in your health programs at home. And so the title of my talk is Behavioral Health Screening Best Practices in Indian Healthcare, and when I get into it, you're going to understand why it's best practices in Indian healthcare. So if you look at the TOR funding announcement, one of the required activities says that we are required to implement service delivery models that enable the full spectrum of treatment. And then it goes on to say that primary care settings may also qualify as evidence-based programs or practices. That's in the announcement. So with our project that I'm working on, we're able to use the TOR funding to actually do the infrastructure and workforce development that we need for our integrated care services. And there's many other SAMHSA grants. I could think of probably 5 or 6 SAMHSA grants that would also support this type of work. So if you want to do something in your programs where you can make a really big difference and where there's a lot of funding, this is an area you should look at right here. Also, the evaluation, education, intervention, treatment services in most states, probably all states, are billable services. So once you develop this in your programs, all of those services that you deliver are sustainable, and that's what we're working on in Riverside. Okay. What this graph is, as you can see here, this graph applies to every Indian health program in the United States because, as far as I know, with the exception maybe a couple or so, pretty much every Indian health program conducts behavioral health screening in their medical departments to be able to report to Indian Health Service for GIPRA. And as you can see right here, in 2004 is when alcohol screening and domestic violence screening started for GIPRA. Then in 2005, 2006 is when we started screening for depression. And then if you fast forward all the way to 2017, which was last year's Indian Health Service National GIPRA report, you can see that we were screening 66, 68, and 69% of our target population. That is not the whole population, that's just the target population. So for domestic violence, for example, that is 66% of women age 14 to 46. That does not include any other age range, that does not include men, it's just those women is what's reported here. And I understand that there's a lot of programs that do more work than that. What this tells me is that there are programs, well, I know there are programs actually that are screening below this national average. There are programs screening above the national average, and there are also programs screening at the national average. So what does this graph show us? This is one area that all of our health programs, this is one area that we can improve and enhance and expand in our health centers. There's room for that. The other thing is if you look at 2018, you can see the GIPRA measures for 2018 and 2019. Some of the GIPRA measures have changed. a little bit. There's been an SBIRT measure added, screening, brief intervention, referral to treatment, which is a delivery model, right, for drug and alcohol. So that's a model that we could use in our programs that would help us with that SBIRT measure. But also take a look at the fact there is no drug use screen. Drug use screen is not a national Indian Health Service GIPRA measure. All of us are doing all this work involving drug use, but there is no drug screen. None. 2 years ago, we did an evaluation of 38 of the 39 Indian health programs in California for the Indian Health Service. I physically visited 38 of the 39 programs and met with their staff. And not one single one did drug screen as part of their screening in their general population. They did it with their behavioral health patients once they were already identified with a problem, but in their general population, drug screen did not exist. And I imagine that's probably very similar to most Indian health programs in other parts of the country. At least I've worked across multiple states with health programs, and drug screen didn't exist either there. So why does it matter? Because there's a direct relationship between screening and intervention. If you have low screening rates, you're going to have low identification rates, you're going to have low intervention rates, right? So if you want to increase the number of people that you serve, the number of people you treat, you have to increase and improve your identification. And one of the ways you do that is you improve and increase your screening. So that's why I feel that this talk is actually very important. Yes, sir. I don't know the answer to that. Sorry. I mean, I think it has gradually become more of a focus, but I don't know the answer to that. But there has been good growth, too, as he mentioned. It's a pretty nice improvement over the years to the point that we're at that point. So if you want to, as Dr. Walker had brought up yesterday, that if you were able to focus on just improving your behavioral health screening for the measures that exist, there are co-occurring problems here. If you improve or increase the number of people you screen for tobacco use or alcohol use or depression or domestic violence, you're going to find drug use in that same population. You will find it. So if you work on improving your work, only if you just focus on those measures, you're going to find drug use. Another option is to add a drug screen to the work that you're doing in your medical departments and start screening. Okay. In 2009, I worked on a national evaluation with the Indian Health Service and the U.S. Assistant Secretary of Planning and Evaluation, ASPE. And what they wanted to know was, out of all the Indian health programs in the country, including your programs, the ones that had the highest behavioral health screening rates in the nation, the highest, according to GIPRA. What are they doing that makes them high performing compared to everyone else? What's the difference? So IHS selected 16 health centers. They took the top 16. 9 of them were IHS facilities. 7 of them were tribal facilities. There were no urban programs evaluated for this particular evaluation. And we traveled across 10 states, 6 IHS areas, and we conducted individual meetings with the medical staff, administration, behavioral health, and data entry staff. And basically what we wanted to do was we wanted to learn from their individual departments, or from the perspective of the different departments, what they thought were their barriers to care and also their best practices. And we looked at a whole bunch of things. We looked at screening, we looked at their treatment services, we looked at their staffing resources, their referral resources. We looked at a bunch of stuff, but for today I'm just going to talk about screening. I'm just going to talk about the screening part. So I'm going to share with you 6 barriers that they identified. I'm going to explain them to you from the way that they explained them. And I'm also going to share with you 6 best practices that they shared with us. And I'm going to explain them to you. So one of the things you're going to notice is that the barriers that they present are common. These are probably the same barriers that you guys have at your health programs. They're not unique. There's nothing extraordinary about them. But there's kind of an important story behind them that I want to share with you. So the first one is, of course, there's not enough staff to always complete the screens. And you have to remember that the screening process is a manual process. It requires staff to be able to collect the information. It requires staff to enter the information into the electronic health record system. And there's a variety of ways that that's done in Indian health programs, but it's a manual process. So if you can just imagine if you have a staff, you have a staff vacancy, you have a shortfall in staffing because of a staff vacancy, right? Or you have a staff person who's on vacation, or a staff person who calls in sick, or you have a medical emergency in your medical department that causes a staffing shortfall. And that affects the screening. It makes it difficult for the screenings to get done. And usually it's the first thing that goes out the window for the day, right? Right, doctor? She's shaking her head, I know, from Indian Health Council. Yeah. The second one, staff doesn't receive enough training. Staff don't know what to do, when to do it, where to do it, how to do it, or why they're doing it. And then they become resistant. Then they don't want to do it. They don't want nothing to do with it. I was in a health center a couple days ago, and I had a nurse tell me, James, I don't know why we're doing all this mental health stuff here. Mental health is not our problem. It's not our issue. We don't deal with mental health stuff here. You guys go and get millions of dollars of grants, and then you make us do all the work. Resistance. Resistance. Lack of training, lack of education, understanding, resistance. And we will see that. All of our programs probably have that. When you have a lot of staff members, you're going to have that. It's a barrier that we have to work through. Lack of standardized process. That means that staff members are doing it different ways at different times. There's no consistency. You have some staff members who are screening, some staff members who are not. You have some staff members that use their own individual questions that they made up. You have other staff members who are using standardized tools. They're all doing it at different times in different ways. It's inconsistent. There's no standard. And it's confusing for the patients. It's a barrier. Community norms often don't see the problem. The problems are so prevalent that they seem normal. Some of our Indian people live in tremendous stress, with tremendous stress and anxiety. Their parents are stressed out. Their grandparents are stressed out. Their aunts and uncles are stressed out. Stress is normal. It's normal to them. I worked with a program one time, and they told me that they had an Indian gentleman who used to sit under a tree every day and drink a case of beer. That was his normal. And if he wasn't under that tree, people got worried about him. The problem is so prevalent that it becomes normal, and that affects screening. Referral resources are sometimes limited. Resources are too far away. They're not directly in the community. They don't have them at the health center. So some programs decide we're not going to screen because we don't have what we feel is good enough referral resources. And then patients don't always answer truthfully. And I think this was touched on a little bit yesterday that some of our Indian people are private. We're all private, all of us. We're all private. We don't like to share our personal information with people. We keep it to ourselves or to our families. I've heard the phrase over and over again in our Indian communities. It's hush hush, hush hush. Don't discuss it, right? It's private, so it's hard for them to discuss these issues, especially to the face of someone else. But also being truthful also has to do with mistrust, staff mistrust. And when you have a program that has a hard time retaining your staff, and you got staff coming and going, coming and going, coming and going, it makes it almost impossible for your patients to develop a trusting relationship with your staff members, with your providers. And then they don't trust them. That's not good. Or if you have a nurse, like the one I mentioned earlier, who has a bad attitude, they communicate that to the patient either verbally or non-verbally. And then so the patient sees that and says, well, if it's not important to that person, it's not important to me either, I'm not doing it. Right? Or if the person actually needs help, then you're thinking, that person doesn't matter to them, I'm not telling them nothing. Trust. It's a trust issue. And you guys could probably think of many other examples in your guys' experience that fit into these three items. Okay. So there are a long list of barriers that they reported, but I just covered the top 6 just because of time. But what I want to point out is that even though these barriers existed, even though they had these barriers, instead of being focused on the problems, which I see a lot in the work that I do, it's easy to come up with problems, they became solution focused. And they worked on developing and identifying solutions for fixing these problems, to the point where they were even able to be identified as the highest performing programs in the nation. So now I'm going to share with you some things that they said were their best practices. And this is from their experience. This is nothing from a journal article, some lit review. This is from their individual experience from Indian Health programs just like yours. And when we approach this, we ask them, if you were to make recommendations to other programs, if you were to recommend to them what they could do to improve their behavioral health screening, what would you tell them? So this is their recommendations to all of you guys, to all of your programs here. These are their recommendations to you and how you can improve your behavioral health screening. The first one is require staff to screen. I think this is probably the most important item on the list. Because if you don't require screening, then staff think it's an option. It's an option. You'll have some staff members who do it, and some staff members who won't do it. So how do you require it? It has to start from the top down. Your board of directors, your tribal councils have to mandate it. Your administration has to require it. It has to be clear to the entire staff that behavioral health screening in our medical departments is a requirement. And the best way to do that is with a written policy and procedure. Standardize the screening process. Again, policy and procedure. Everything needs to be documented. Everybody has to have the same information, understanding what to do, when to do it, where to do it, how to do it, who's responsible, what standardized tools to use. And not only just for one health center, but across the entire health system. If you have more than one health center location, that needs to be taught across the entire health system, so that patients have the exact same experience no matter where they go. And then, of course, we have the trained staff on the screening procedures. One thing I want to add in here, too, is that if you're able to, one of the things that's beneficial about doing behavioral health screening in your medical departments is you're not only collecting patient-level data so that you understand what patient needs are, so you can deliver services to them. Do they have a drug use issue? Yes or no? Do they have an opioid use issue? Yes or no? That's what you're identifying when you're doing drug screening. But over time, when you're collecting all this information, 6 months, a year, 5 years, 10 years, that becomes your prevalence data. That becomes your prevalence data. That helps you to understand what your patient needs are. When you apply for a grant, you don't have to go to a household survey data or to the county or to the state or to a university. You look at your own data for your people, for your community who walk through your doors every single day. You look at your data, and you make decisions based on your data and your people, not everyone else. What's happening in Minnesota may not apply to what's happening in California. What's happening at the Pechanga Reservation may not apply to what's happening at Hoopa or Pitt River in California. So when you have that prevalence data, it's important because you can use it to train your staff and to teach them so they understand why they're doing what they're doing. Our patients have a depressive symptom rate of 28.6%. Depression, 14.8%. The national average is 6.4%. Our depression rate is more than double. They need to know that, so they understand why they're screening their patients for depression and suicidal ideation when they're coming into their clinics. They understand how important it is. Screen all patients during each visit. I'm going to focus on the all patients for a second because, in my opinion, the Indian Health Service GIPRA measure should be a minimum standard. It is not the standard. It should be a minimum standard, in my opinion. For our Indian people, it's not good enough. It's not good enough. It needs to be better than that. And the problem is that when we are screening just a select few, a targeted population, and we don't screen our entire population, we are not giving equal access and opportunity to all of our patients, and that's a problem. In our tribal communities especially, we need to serve our whole community, our whole population. Aunts, uncles, together, alike, the same, right? Because they all live next to each other, they influence each other. We have to serve the whole community. Doing things the GIPRA way is a minimum standard. It should not be the standard, and we need to change that in our programs. And we cannot rely on Indian Health Service or wait for IHS to tell us to do it. We need to do it on our own. We have to decide at some point what is really needed for our people, and we need to do it. We need to make it happen. Screen, even if referral resources are unavailable, these programs decided they were going to do that. They decided they're going to provide at least some basic education, some support. Now, I'll tell you that the literature, for example, with depression tells you that if you don't have resources to serve a patient with depression, suicidal ideation, you shouldn't do the screen. That's the literature. As we discussed, though, the literature is not always right, so that's a decision you guys need to make with working with your patients in your programs. But these programs decided they're going to do it anyway, and they're going to try to provide some support and some education and do the best they could. And then, of course, improve staff communication. We also touched on this for a moment yesterday as well. Trying to find opportunities so that staff across departments can communicate and work together. They talked about patient care teams. They talked about having joint staff meetings, joint trainings, trying to share as much of their health record as legally possible so that they all have the same information. Even establishing organization-wide committees where you have large groups of people across multiple where they have multiple departments across the organization all working together. Because you know why? That creates accountability, and it's effective. And it also creates support too. Okay. So one participant said that we screen everyone because you never know when you're going to hit somebody that has problems. Domestic violence or alcohol or even all three screenings, it is a respect of no person or status. It doesn't matter if you have a diamond necklace or if you have an old ragged t-shirt, you're going to get screened. That's a really important statement because some providers, and I love our providers. We have providers that are amazing. But we have some providers that think, you know what, I've known that patient for 15 years. They're fine. They don't need to be screened. But they don't know. They don't know. There's actually a journal article where they evaluated the interaction between providers and patients, and they found that in most of the time, when patients would bring up a behavioral health issue or a symptom, the providers would ignore it and change the subject. And when the patient would bring it up again, the provider would change the subject again. And then the patient would drop it. So what's the point? We shouldn't solely rely on our providers to identify these problems. Our providers do a great job at it. They do identify a lot of problems. But I would challenge our providers, our nurses, and our medical doctors who are here today to pay attention to your patients, listen carefully, and if you hear that, take the time to discuss it. Don't ignore it. It's important. Okay, so some of the benefits that they reported for using these best practices is that it's easier to screen everyone. It's easier. It becomes like your vital routine, you know, like all of us, we go into our doctor and we have the vital routine, we get our blood pressure and our weight, and nobody ever questions why are we doing this vital routine, right? Because we've always done it. I've done it my whole life. We've all probably done it our whole life. It's part of the routine. It's normal. It's standard. We expect it every time we go. But it's easier to screen everyone because you don't have anything to keep track of. You don't have to track who needs to be screened, who doesn't need to be screened, who has a problem, who doesn't have a problem. You just screen everyone every time they come in. It's part of the routine, just like your vital routine. The staff grow more comfortable with the questions, and competency increases over time. The more they do it, the better they get at it, the faster they get at it. their competency increases, their comfort level increases, and it does away with that resistance. And then patients also grow accustomed to being screened. They get used to it as well. Like I said, it's part of the routine. They start to learn that it's what they do with everyone, every visit. It's just part of the routine. Patients don't feel singled out. You can imagine that if you do screenings and you're screening 50, 60% of your population, your target population, you're going to have some individuals that may not be screened for years. And then they come in one day, and it's their turn to be screened. They're like, wait a minute, I've been coming here for years. I've never been asked any of these questions. What's going on? Why are you asking me? And the walls go up, right? Because they feel like they're being singled out. And then screening at each visit increases the chances of identifying people with problems. This is a really important one because the program's reported that sometimes it takes 5, 6, 7 screens before they finally give a truthful answer or before they're ready to get help. So they'll give false information all the way up until that point. So if you screen a person every 10 years, you'll never get the truth. You'll never give them the opportunity to get help. That's the reality. And then finally, people's circumstances change. There are situational problems like depression. You can have a person who has a perfect life today, and tomorrow they experience a tragedy. The next day they go into the doctor, and their emotional and mental state are completely different. Situational problems. They also reported that they have patients with domestic violence issues, for example, who come in to your health centers. They come in with their partner who's victimizing them. They can't tell you the truth. It puts them at risk. But they've had people that have learned that, well, they screen here every time I come in here, and they've had people who have intentionally made appointments to come in and be screened as a way for them to reach out and get help. Just think if you didn't make that available, right? Okay. So those are a few tips. I want to share with you a project that I'm working on in California with Riverside, San Bernardino County Indian Health. This is our TOR project. We also do a Native Connections project, an MSPI project. We're a hub and spoke. And so I want to share a little bit of application now of this. We're trying to apply these best practices in the work that we're doing there in Riverside, and so I want to tell you a little about it. Riverside, San Bernardino County Indian Health has about 86,351 American and Alaska Native people in their catchment area in both San Bernardino and Riverside County. San Bernardino County is actually the largest county in the United States, so it's a pretty large area. They have 49,000 registered patients. They serve 9 federally recognized tribes with through 7 health centers. So they're the biggest in California, but they're definitely not the biggest in the country. There's much bigger programs across the country. But they're similar to you guys in some ways in that they have a couple of larger health facilities that are stationed in sort of more metropolitan areas, and then they also have several health centers or clinics that are in very rural locations. And so they have a kind of their setting is really different. And they have all of these kind of different challenges with long distances between clinics, a couple hours from one clinic to the next, and trying to get staff who can work in those particular locations, and all the things that you guys experience. They have those same challenges. But I want to say that they've been operating for 50 years, which I think is great. And they were established by the tribes in the area, so they're very well connected with the Indian people and the tribal community. What I want to do is I want to share with you, one of the first things we did was we created our policies and procedures for our integrated care program. And so I want to share with you our policy screening because that's what applies today. I'm going to try to read this. It says, all medical department patients, regardless of gender identity, sexual orientation, race, or ethnicity, insurance coverage, purpose of the visit, or physical mental disability will be screened for behavioral health problems according to the following preset established parameters and settings at every visit during the vital routine using screen docs. I'm going to explain to you screen docs in a minute. But so what this policy is basically saying is we're screening everyone. It doesn't matter who you are, what your race is, how old you are. We're going to screen everyone. Well, it does say how old you are because we do have a limit, but we're going to pretty much screen everyone. And so for tobacco exposure, we're screening once a year according to the IHS definition for all ages. Tobacco use once a year per the IHS definition for starting at age 12. Alcohol use also once a year, annually, age 12. And then we're also doing non-medical drug screen using the DAS-10 each quarter. This is for our TOR project, starting at age 12. And then depression, suicidal ideation, and domestic intimate partner violence every visit. The reason why we started age 12 is because in California, a youth age 12 does not have to have permission from their parents to receive mental health services. So it makes it a little easier for us. This goes on to a procedure that explains exactly which staff are supposed to do the screening and how it's supposed to be done, and it goes into all that, but I just at least wanted to share with you the policy so you guys can see what the policy is. Okay. A little bit about screen docs. This is a new innovation that we created for Indian healthcare. We've been working on it for years. And essentially what it is it's a software application that allows our health programs to be able to screen patients electronically using a touchscreen kiosk or a handheld wireless device. And what's great about this application is it doesn't require staff to do it. So it allows your medical staff to do other work, and it allows for the patient to privately self-report their information. Most of the screening tools are self-report tools anyway. And it also standardizes the process, so the screening is done exactly the same way every single time across every single health center. Exactly the same way. Patients have the exact same experience everywhere they go. So of course, working in the medical department is a very limited amount of time. Screenings can't go on forever and ever and ever. There are a lot of tools out there that are very complicated, very long. There's not time for it. So we have to use the briefest tools that we possibly can so that we can process a patient. And so what we do is we use general questions like, for example, do you drink alcohol, yes or no? And if the person answers yes, then we give them a standardized tool to evaluate them for alcohol use problems. If they answer no, then it bypasses the standardized tool and it goes to the next measure. So someone who's negative, the screening is very fast, right? If they stop and answer a standardized tool, it takes them a little bit longer, but so far, it is not disruptive. It actually takes longer to do it all by hand than it does to do it electronically. We also have created some system settings where we can actually customize the age, the minimum age for screening for each item, for each measure. So we could actually set a different age for each measure if we want. And the software knows the age of the person and will screen them according to their age. We can set the frequency of screening for each item. So if a patient came in today for the first time of the GIPRA year, it will screen them for everything. But if they come in tomorrow for a follow-up, it will only screen them for depression and domestic violence, or items that are set for every day. It won't screen them for the other items. So it makes the screening quick. And then we also have on and off capability. So if we decide at some point in the future we don't want to screen for drug use anymore, we turn it off and it won't ask any drug use questions. So it's very customizable. It's also an integrated care management system. We can track our visits and our referrals and our follow-ups in the system. It helps us do that. And then it has some really powerful reports. We talked a lot about reports. We put a lot of information in our electronic health record systems. When it comes time to writing a grant or we need to have information, it's almost impossible to get the information we need. Impossible. It's useless sometimes. So in ScreenDocs, we created these dashboard reports that allows us to see what our screening rates are by measure, but we can also see them by individual severity levels. So for the PHQ-9, for example, there's 4 severity levels. There's mild, moderate, moderate, severe, and severe. We know how many patients, how many unique patients screen positive for each individual severity level. You know how useful that is when we're trying to get money? Very useful. We know that information by any age range. We can customize the age ranges so we can see the age range of interest, and we can see that information by age range. And we can also see it by individual clinic locations, so we can evaluate what are the screening rates for Pachanga versus Morongo versus San Manuel versus Torres Martinez, or what is the screening rates for the entire health system, aggregated. Very, very powerful, very fast, real time. As patients are screening, it's all automated, automatic to the dashboard. It's real time. There's no sorting. There's no trying to figure out what these numbers mean. It's pretty clear. Okay. What I want to do is I get asked a lot of times, what do the staff members think about doing universal screening, especially electronic screening? So we put together a video. Now we've been really working a lot on our depression and suicide intervention, because we have a very, very high depression rate and suicide rate in our communities. And so when they talk in this video, they're going to be talking a little bit about depression and suicide also. But it shows you kind of how the staff feel about doing this kind of work. Let's see if I can play this. Nope. We created ScreenDocs, an electronic behavioral health screening application that helps to eliminate the barriers and apply the best practices reported by the Indian health programs we evaluated. And over the last few years, we've had the opportunity to be able to test and demonstrate ScreenDocs at Riverside San Bernardino County Indian Health, the largest tribal health organization in California.
Our first step is to do the we put them in a weighing scale, but they're pretty much close together. So after that, they go stop by the kiosk. 9 above, we will print out the result and give it to the doc. That's our cue to them, to let them know that that needs to be properly addressed.
I'm glad to see that this is done on a regular basis, because prior to us trying to integrate behavioral health screenings with medical visits, if the patient didn't mention it, we generally didn't ask unless there was a reason, unless the patient was crying or something else, or if the symptoms didn't fit, then we'd start thinking, well, maybe it's behavioral health. But what you're finding out is that people are very comfortable with entering information that otherwise they wouldn't disclose, like about domestic violence or having suicidal thoughts. And the more providers are aware of this, the more we can do for this. And it also serves as the basis for us providing and procuring resources for the patients to get treated. It's all tied in, you know. We've known that, but we, as a system, have not addressed the issue of the whole person, just the body, if you would. Although in family medicine, we know that, you know, if your mind is not all right with you, then it affects everything, and vice versa. So this is very nice, very effective, very cost effective, and it has helped my patients particularly quite a bit.
Initially, I was not real excited about the whole ScreenDoc approach. It didn't make sense to me to have a native person go up to an electronic machine and reveal their intimate feelings. It just didn't quite fit for me. Then I had a couple of experiences. One was a patient who went to medical, and he indicated in the ScreenDoc that he was suicidal. And then when they inquired about his feelings in medical, he denied it. So they brought him down to see me. And initially when I sat down with him, I realized that there was some conflict there. He said on one hand that he was suicidal, but on another hand, he said he wasn't. After talking with him a little bit, I realized he was suicidal. And we talked things out for a bit, and then he agreed to come back and see me for 3 times. And he also felt better after talking to me. But the point is, I would not have known that he was suicidal, because he was not a behavioral health patient. I would not have known had he not gone to medical first and did the ScreenDocs. And by doing the ScreenDocs, then I was able to capture this individual and help him. And that's really special. That's a special feature of ScreenDocs, and I value that. So it's much more user-friendly for the native people than I realized.
One of the key features of the kiosk, the system that as it is set up right now, it allows us to know not just the total number, but allows us to know how many people are walking into the San Manuel Clinic or the Torres Martinez Clinic or Anza or Saboba. Regardless of the clinic that they walk in, we will be able to take this information and use it to shape how we assign our staff, to how we assign resources, special programs. It'll allow us to shape how we reach into the community for social programs, for recreational activities. One of the most tragic things that I can imagine is to have someone walk into my office and speak of a child whose life has been lost due to depression, to suicide. It's tragic when a child comes in and talks about how they've started self-harming to deal with their distress. The information that we gain from these kiosks will allow us to directly look at the community that is experiencing the suffering, to see where we can be of best effect in creating change with our resources.
For the past couple of years, I've been doing some work with our Native Connections grant, and part of what I do is I go out and I interview people in the community. I have been able to interview 86 people from 12 different communities within our organization. Part of what I was finding out by doing these interviews is that people are unaware of any of the prevalence data or how to access any of the data that have to do with depression or suicide. So in our clinics, we're using the Screen Docs kiosks to be able to assess people. And part of what we're doing is we're collecting a lot of good prevalence data on suicide, drugs and alcohol, domestic violence, all kinds of different things that they are being screened for in our clinics. With all this data we're collecting, we're able to take this data back to go out to the community members to show them why we screen and why we're doing the things we're doing. And it also helps them to be able to get involved with what we're doing as well.
I like the idea of the kiosks. It's a way for our people who don't normally talk or like to talk about things, for them to communicate without actually communicating, so to speak. And I think that it's been of value to us, of added value. We can capture a lot more because we're feeling like we're not actually saying things we're not supposed to, because it's not verbalized, although we're communicating. I think it's one of the best ideas we've had in a long time.
It is our vision that Indian health programs nationwide will be able to use Screen Docs as an easier way to screen more patients, to offer real-time early intervention, and to generate easy-to-use dashboard reports that help us to know what are the behavioral health problems that we need to focus on for each community served. All right, great. So what I want to share with you real quick is just some of our prevalence data that we have obtained from doing this screening. And also what I want to tell you is that when we first started electronic screening 5 years ago, we basically installed it and implemented in one of the health centers just so we could test it and demonstrate it. And then in year 2, we expanded to the second health center, then year 3, the third, and today we're actually using it across all 7 health centers. So the data that I'm showing you for the last 5 years is not reflective of universal screening electronically across all 7 health centers. It's actually reflective of our gradual startup. But I wanted to share with you the numbers so you can kind of see what we see. We conducted 34,211 behavioral health screens for 14,287 unique patients. And of those patients, 1,524 screened positive for alcohol problems, 3,800 individuals screened positive for depressive symptoms, 710 screened positive for suicidal ideation, and 206 screened positive for domestic intimate partner violence. And what's important, like Dr. McMichael said, is that a lot of these people may have been missed in the past because of the way that the screenings were done, but because we're focused on trying to universally screen, we're picking up a lot more people, identifying a lot more people, and able to help a lot more people. When we started our TOR project, we added DAS-10 as a screening measure. And so in the last 5 months, we've screened 3,445 unique individuals just in the last 5 months. And of those, 259 individuals screened positive for drug use. And I wanted to share with you what we know about the drug use, the choices As you can see here, that our patient population has a problem with marijuana and methamphetamine. Marijuana is number 1, methamphetamines number 2, amphetamines number 3, probably could be combined in the same category. Alcohol, and then opiates is the last one on the list. And there's other drugs too, but so 11%. This is an example of a report by severity level. The DAS-10 has 4 severity levels, and there's treatment actions that go with each severity level. And I'm not going to go through all the numbers, but I just wanted you to see them. We can actually generate this report by any age grouping that we want to see. And it's real-time, automated. We can look at these reports all day long if we want. But for age 12 to 17, 13.8% screen positive for drug use. Age 18 to 25, 11%. And age 26 and older, 6.5%. And we expect these rates to increase because our experience with the other measures is that the more that we do it, the rates go up. The more comfortable they get with it, and the rates go up, the rates increase. So we expect the rates to increase too. Because of our TOR project, we've added a few new features. We've added drug of choice inventory, so when we screen patients with it, and they complete the DAS-10 and they screen positive on the DAS-10, it actually gives them a drug inventory for them to identify their primary drug of choice. Then it will give them a second inventory for them to identify their secondary drug of choice, and then a third inventory for them to identify their tertiary drug of choice. We want to know not only does the patients have a drug use issue and severity level, we want to know what drugs they use, they report to use. And of course, all that goes into a database. So just think about how important that information is, that we can look at each clinic by age range, and we can see the exact drugs of choice that are common within our patient population. We also decided to start doing demographic surveying. All the demographic survey stuff that we have to collect with our grants, we decided to start doing it at the kiosk also because it's easier. It's easier for patients just to fill it out electronically. It hits the database, and then we have a patient profile for all of our clinics. And of course, we added the system settings so we can turn those off if we want. If we don't want to collect drugs of choice or demographic data, we can turn it off, and it won't ask any of those questions. And then, like, as I mentioned already, it populates the reports. Also, we created an option where we can export all of this data into Excel files for data analysis later for research if we wanted to. So I hope this presentation was somewhat helpful, and I would like just to encourage everyone to go home to your programs and take a look at what are you doing with your behavioral health screening. Is there any opportunities for you to enhance or expand your screenings to improve it in any way? And also look at your reporting and see because you guys have been putting this information into your health records for a long time, and look at what type of data you can get out of that, and if there's any way that you can improve the data so that you actually get something out that's meaningful and you can use for your programs. I want to thank everyone. If you have any questions, please feel free to come and see me, or you can call me. And thank you, everybody.
Thank you very much, James. That was very helpful and hopeful, so thank you very much for that. We do have a few moments if there are any pressing questions that anyone has for James before we break for the day. And perhaps I didn't introduce that as best as I could. Let's bring the microphone here. Do we have it, or is Cindy? Oh, Jeffrey has it today. Let's go over here to our recovery coach. Did I see another hand on this side? No? All right, so we'll return to the questioner or commenter.
Okay, I actually have a couple of them, so I'm not going to ask them all. I'll see you after. When you said that there's lack of training, why is there such a lack of training when it's so important that it's done? Because how do we get our information if the staff is not being trained properly And how come there isn't enough staff?
Those are loaded questions. That's the point.
I have a couple
that's
more
the point
just
that,
like that,
that's the
so.
point is so important that you think would be a priority, but in this particular setting, it's not always the priority. And so the point is, it just needs to be. And I don't want to generalize and say all health programs across the country are the same, because they're not. They're not the same. I mean, just the information I presented on the high performing sites is an example that there are programs out there doing really amazing work. They're not all the same. So I don't want to generalize. I don't want to generalize all providers either, because there are some really amazing providers. But you're going to have every once in a while those other people who, there's problems. And we all have them. I think we just have to figure out how to work around it. But I don't know the answer. The funding issue is a whole nother discussion. And the training I think is just a lack of priority. And that's the point I'm trying to make, is that we should make this a priority. It's so critical for everything that we're doing that it should be a priority. And that's just the point I'm trying to make.
Okay, now on my territory, we have a health center. We do have IHS, but the problem with our IHS is they don't have a building. So they're kind of like in the basement of the health center, which is really kind of crazy when we find out how much more they could do if they had a building. And so would we be able to do this at the health center and maybe even at Blossom? Would we be able to do the screen docs? Or does it have to be a federally?
No, it doesn't. No. We actually created it for all Indian health programs, tribal, urban. It is a database, so it does require to sit on a server or in the cloud. But if you have a network, you can connect the database to the touch screens and it will operate just fine. So one more back there.
Is there another question?
Yeah, right there.
Hi, first of all, I want to say I'm pretty impressed with that. I've helped develop quite a few AHRs and worked with AHRs for about 20 years now. So my question with that, and yes, I am impressed with it. I like the if-then type of logic that it uses. How do you integrate this into your EHR and into treatment plans or into clinical encounters when the people come in? Is that integrated into that clinical encounter or into that treatment plan, or how's that side of it work?
Yeah, thank you for that question. I didn't comment on that because of time, but it actually electronically exports all the information to the EHR. Currently, we currently have an automated electronic export to the RPMS. So it takes all the information and puts it into the Exam and Wellness tab in the RPMS real time. So as the patient screens and finishes the screenings, that data hits the RPMS real time for the providers to look at. And then Riverside is a next-gen site in California. Majority of the sites use next-gen, and the same thing. We have a interface for next-gen, and basically we could interface it with any EHR. The interface is not that difficult to create. So but it does have the capability of electronically exporting all the data. The whole point is that we want to make it easy. We want to take the responsibility off the staff members and let the software do the work. That's the point, so that it saves time. And then, if we can save time, then it makes it more likely that the work's going to be done. That's the point.
Thank you. I actually have one that I'm working with right now that's working with 37 different tribes for their EHR. We'll be in touch with you.
All right, awesome. I'd love to talk to you. Sure.